Good morning, everybody. Today we'll be talking about pleural effusion, especially the pleural disease out of which pleural effusion is important. So normally pleura, it contains two layers, the parietal pleura and the visceral pleura. So the fluid usually, the pleural fluid enters from the capillaries of the parietal pleura and it is drained by the lymphatics of the parietal pleura. So today we'll be talking about pleural effusion. So how can pleural effusion occur? Either there is increased production or it is decreased drainage. So fluid can enter through the visceral pleura, through the capillaries, from the visceral pleura, from the interstitial fluid of the lung to the visceral pleura to the pleural cavity, or it can come from the abdomen through the small pores in the diaphragm, or pleural effusion will only occur when the lymphatics are not able to take out the fluid. Normally, the lymphatics are able to take around 20 times the amount of fluid. So for pleural effusion, first we have to distinguish between whether it is a transudate or an exudate. So because for exudative pleural effusion, you have to have additional diagnostic studies to find out the cause and further management of the case. So transudate will occur due to the systemic factors and exudate will occur due to the local causes. So first distinction between important is the transudate and exudate. So here important thing you should learn is exudate. So exudate starts from word ex. So exudate means excess of things. So for that, put a light on the things. So that is known as a light criteria. So I've already told you excess. So in exudate, the protein of the exudate divided by the protein of the serum, it will be more than 0.5. So it is excess. And LDH will be more. So there is two criteria in that. One is it is more than the ratio between the pleural fluid LDH and the plasma is more than 0.6. So that means around 60%. And third criteria is correlating with the second criteria. That is more than 2/3 of the LDH in the plasma. So that amount to 66%. So it is very easy. So you can remember that protein more than 0.5, LDH more than 0.6, and or more than 2/3 of the upper level of the plasma. So first we'll talk about the transudative pleural effusions. So I've already told you the three most common causes are the most common cause is the heart failure. So usually in the heart failure, it is because of the primary factors, what we were talking about, the Starling law. The three things, there's more increase in the interstitial pressure, the hydrostatic pressure. So that is the cause of the pleural effusion. So usually the pleural effusion will be bilateral and it will be so already told it's a low protein and a low cell count pleural effusion. So usually it's bilateral. There may be some asymmetry, but there is no pain in the during the pleural effusion. So if there is a pain or it's a unilateral, you have to do a thrombosynthesis to tap it and look for the protein and the cells. So I already told you increased hydrostatic pressure found in the heart failure. So in that you will have a increased pro-BNP levels, anti-pro-BNP levels will be increased. Then other cause will be a decrease on cardiac pressure. So it will be found in cirrhosis and in renal disease, especially nephrotic syndrome. So next important thing is exudative pleural effusion. So I've already told it's more important to diagnose, and because we have to do additional diagnostic studies. So exudative pleural effusions in India, we are not talking about the western side, they have different causes. In India, the main things are associated with pneumonia, that is bacterial pneumonia, and in that category we can also say it needs a special mention, that is tuberculous pleural effusion or tuberculous pleuritis. Then is malignancy, viral infections, and pulmonary embolism. So first we'll talk about the pleural effusion associated with pneumonia. So that is also known as synpneumonic effusions or parapneumonic effusions. So as we already told, the involvement of the lung, and it causes inflammation in the pleura. So initially, to start with, the synpneumonic may be sterile initially, but later on secondary infection occurs and it will be a high protein fluid. Okay. Normally we get a X-ray done, and if there X-ray CT done, if the distance between the side of the lung and the pleural is more than 1 centimeter or 10 mm, it has to be tabbed, and you have to see for the protein and the cells. So the exudative effusion results from increased capillary permeability characteristic of inflammatory condition. This type of effusion occurs secondary to condition I already told you: pulmonary infections, pulmonary malignancies, and pulmonary embolism. So we tap it and then we look for the cells. Then further is important is, if it's a large effusion, we have to give antibiotics and we have to tap it. We can do one thracocentesis. If we take it for only for sampling, that is known as diagnostic thracocentesis. And if there is for therapeutic, then it is therapeutic thoracocentesis. So for therapeutic therapy, you need to have a large amount of fluid, and it has to be subject to cytological studies and biochemical studies and microbiological studies. So all three studies are important in that. So therapeutic thoracentesis, a simple thing, more than that is required in a pleural effusion with 5 criteria. That is very important. One is, you have to remember it like this: is first is if there are septa in the pleural effusion. Second is presence of frank pus. So these are all gross criteria. In the book, it's given it's written like first is and the 5th criteria. Now in between criteria, that is how I remember. One is the pH less than 7.2. So, but here is the thing you have to learn is, we don't subject our machines to find the pH of the pleural effusion, because it may cause some damage to the machines. Other is if the sugar is less than 60 milligram %. So that is a low glucose. So low glucose you can also have in rheumatoid arthritis also, or in infections in which, why there is decreased glucose? Because it is used by the bacteria. So taking that point further, the 3rd point or the 4th point in the line is you have a positive gram stain or a culture positive. So telling all the 5 things. First is there are septa in the pleural effusion. Okay. Second is pH less than 7.2. Then sugar less than 60 milligram. Then a positive gram stain or culture positive, or last is presence of frank pus. So other name for septate is loculated pleural effusion. So loculated effusion, you need a ICTD, that is intercostal tube drainage. Then other causes are tuberculous pleural effusion. So you might be knowing that in tuberculous effusion, what will you get? In the cytology, there will be increased number of lymphocytes. Then in the protein, it will be increased. Already told you. Then sugar may or may not be low, depending on the condition of that. Then ADL levels more than 40 international units, or gamma interferon level more than 140 picograms per liter per deciliter. If they are increased, then, but usually in our setup and in India, we usually go for ADA enzyme. If it is more than 40, we consider it as tuberculosis. Then plus we can get we can get a pleural biopsy, we can get a pleural culture for AFB, then we can do abrasion of the pleural cavity or take a pleural biopsy for tuberculosis. Then other things important are the cancer. So typically 3 cancers, you can learn it like LLB, lung, lymphoma, and breast. So lung and breast, female would be breast, lung, both lymphoma. So one thing you have to remember is in India, we start with the workup for tuberculosis. And if it is negative, then we can start diagnosis of lymphoma. This is how we go about. Then one thing, I just tell a case about the things. A patient is started on ATT, he is not improving. So the two options the two possibilities would be either it's a drug resistant tuberculosis or we are missing the diagnosis of lymphoma. Then other conditions which are important are the of the exudative are its association with pulmonary embolism. So pulmonary patient may have a chest pain, conditions predisposing to it. The sex more common with pulmonary embolism is female. This around the pregnancy, there are more chance of, then if he or she is having any procoagulant factors which can increase the chance of pulmonary embolism. So it will be so the treatment of the pulmonary embolism or due to this pleural effusion will be the same like pulmonary embolism. But if the patient has increased chest pain, we can keep that it has converted from a pulmonary embolism associated pleural effusion to hemothorax. Then other cause which I already told in this is also peritoneal dialysis. We already told about this mechanism already. Then so clinical manifestations according to the disease. So pneumonia causing fever, chills, and pleuritic chest pain. So the pleuritic chest pain will be pain increasing with inspiration. So patient will try to lie on the side of the infection. If the patient is having right sided pollution, he will lie in the right lateral position. So malignant pollution, in malignant pleural effusion, you may have dyspnea and coughing. And dyspnea will be out of proportion to the amount of pleural effusion. That is the thing you have to remember. If the patient is having dyspnea, which is out of the proportion to the effusion, then you have to keep a possibility of malignant pleural effusion. Then clinical findings we can discuss in a second, that the site may be prominent on inspection. The trachea may be shifted to the opposite side in case it's a moderate to large effusion. The on percussion, the note will be stony dulls. Tactile vocal fragments will be decreased or absent. Then breath sound may be decreased or absent. Usually it should be absent, but you may have a patch of bronchial breathing just above the level of pleural effusion. Then diagnostics. For diagnostics, we get a chest X-ray or an ultrasound done. Chest X-ray, we can get a PA view as well as the lateral view, and usually we can see a rising level. But classical, we get a ultrasound done. Why ultrasound is done? Because it's totally a non-invasive. There is no involvement. There's no exposure of the patient to the X-rays. Then we can mark the site. We can even do a ultrasound guided pleural effusion thoracocentesis. But according to new rules, you should always mark the site for tapping of the pleural effusion because it comes under litigation. Then we already told about you have to do a cytological studies, biochemical and bacteriological studies. So X-ray, the CP angles are blunt. It is shown in this figure. Then the management will depend on the cause of the pleural effusion. And here a little mention about the malignant pleural effusion. Already told you that if it does not get relieved with one thoracocentesis, you may have to do a pleurodesis or keep a small cannula for the pleural effusion. Thank you.